Welcome to Eyes On 2023 and Exploring the Dry Eye Pipeline. I'm Dr. Damon Dierker. I am co-founder of Eyes On Dry Eye, and I'm excited to be part of the festivities here at Eyes On 2023. I am honored to have my esteemed colleague, Dr. Walt Whitley, as my co-host tonight on Exploring the Dry Eye Pipeline. How are you doing, Walt?
Doing awesome. Excited about this discussion we're about to have.
Fantastic. So this is definitely a presentation I've been looking forward to because there's so much going on in the U.S. as we look ahead to 2023 in the ocular surface disease space, whether that's dry eye, MGD, Demodex blepharitis. There's a lot of technology that's happening in our offices. There's a lot of things in the pharmaceutical pipeline. Walt and I are going to hit the highlights to get you ready for 2023. We want to make sure that you make this as interactive as possible. We're going to be engaging throughout the chat line the entire time. If you have questions, comments, conversation between Walt and myself or our other attendees, really utilize the platform here on Eyes on Eye Care to be able to have the best experience tonight with the presentation. My disclosures along with Walt. So to get started in this interactive format, what advances in OSD are you most excited about? I know what I'm excited about. I'm interested to hear what Walt's excited about, but I want to hear what you're excited about because we have attendees from all over the country, really all over the world at Eyes On 2023. What is it that gets you going in the OSD space? Is it diagnostics? Is it therapeutics? In-office therapy, OTC? What are you most excited about? And I'll get that going in the chat. But Walt, what is the things that are happening today that you're most excited about in the OSD space?
D, all of the above. We've had this conversation before, Damon, where we're looking at when it comes to diagnostics. There's a lot of different tests that we've utilized in the past, but think about objectivity and what are some of those objective testing that we have. And so we're going to see more and more technologies that are going to help us to determine, is it inflammatory? What are the inflammatory markers? Even potentially down the road is when we talk about some of the newer drugs that are out there, if there's a way we can detect biomarkers within the tears, we can measure it, but then if it improves, that's going to be a sign that we have right there. But also when we look at the clinical studies and clinical research studies, if we can show improvement within a biomarker of dry eye disease, that's only going to help us know that these technologies and these drug devices or pharmaceuticals do work. But when it comes to treatments, there's so many ways for us to target the various tissues. We're going to talk about some of the meibomian gland treatments. Demodex is a hot topic that we like to talk about. Our patients don't like to talk about as much when we tell them about it. But I can go on and on. Of course, I was very vague, but we want to hear what you all are excited about because we're going to talk about a lot of these excitements. What about you, Damon? What are you excited about?
Well, I think what you're hearing and what I see in our chat and what I hear from you is that it's really understanding what is the best treatment for our patient. It's getting to a diagnosis that's accurate using point of care diagnosis, osmolarity, MMP9, meibography, doing our exam, coming up with a true diagnosis, and then trying to match the therapies that we have now and that we hope to have in 2023 and beyond to that exact patient profile and be able to set the right expectation for the patient. Switching gears to, what are we excited about? We're excited about that process continuing to evolve, but what challenges and unmet needs do we have in OSD? And I really want to hear from you, our attendees tonight. What is it that you feel is the biggest gap that we have? Because we want to understand where we're at, where we're going. And Walt, when I ask this question to you, what is the biggest unmet need that you see in your clinics in Virginia every day?
When it comes to the unmet need, I think one of the biggest things, and we'll talk about this here shortly, is drug delivery. And how can we get the drug into the target tissues to render its desired effect, whether it's going to be the symptoms for our patients or the signs that we have. And so speaking about drug delivery, we know whenever it comes to treatments for dry eye or ocular surface disease, when it comes to pharmaceuticals, the site-specific therapy, we know it gets into the tissues, whether it's the conjunctiva, whether it's the cornea, what effect is it going to have? And so that's one thing that we're seeing in a lot of the different newer pharmaceutical agents when we're looking at cyclosporin, the 0.09% with the N-cell technology. The drug is within a hydrophobic core surrounded by a hydrophilic shell that's able to penetrate through the tears and find its target tissue, which is going to be both the cornea and conjunctiva. If we look at some of the studies, we can get anywhere between 3 times higher concentration within the cornea with the cyclosporin 0.09% with Cequa, or within the conjunctiva, about 1.3 times greater conjunctival penetration. All other things, the loteprednol 0.25%, and Damon, you've prescribed this a lot, and I have as well, where we're treating the dry eye flares and utilizing mucus penetrating particles with a smaller drug size to help it penetrate through the tear film mucins and to find the target tissues, whether it's the cornea or whether it's the conjunctiva. And just looking at some of the studies, by improving the penetration, we're able to see improvements in the symptoms. And if we look at the STRIDE-1 data for Kala Pharmaceuticals and the Isuvis formulation, we're showing improvement within the symptoms as early as day 4. And so, what are some of the strategies to improve topical ocular drug delivery? Well, one, we can increase the effective dose. We can use the drug a whole lot more. We can increase the concentration, which we've seen in several different medications. We'll talk about some of the pipeline where it went from 0.05 cyclosporin to 0.09 to potentially 0.1% that we may have in the near future. Molecular design, I just mentioned the mucus penetrating particles as well as the N-cell technology that we're seeing from some of the drug companies, but also the formulation science. How can we get the drug into the target tissues? Do we need a thicker or more viscous agent? Or is there novel drug entities or drug itself that can increase residence time on the eye? And so these are just some of the strategies that we have. Others that we haven't. One of the things that Damon and I talked about before is iontophoresis. And this is something that unfortunately it did not make it through the pivotal trials, but getting dexamethasone and using electrodes to help get the drug to penetrate into the target tissues. But this drug delivery, we're going to see this more and more. We know that with the drug, but the other issue that we've been addressing as well is going to be, are the patients taking it? Actually, Damon, how compliant are your patients when it comes to taking their medications?
Yeah, we know that patients, especially if they're on a chronic dry eye medication, there's definitely challenges where you look at the data and maybe your typical patient on chronic therapy is only going to get one of their RXs filled. Maybe they're on it for a month or two and then they forget about it, or maybe they're feeling better and they decide not to take it, or there's adverse events. We know that compliance in optometry and ophthalmology for really all of the things that we prescribed are really not very good, whether that's dry eye or glaucoma. So hopefully these innovations that we are seeing now with molecules that we've known and loved for a long time, cyclosporin, loteprednol, dexamethasone, improving our delivery systems. Then we have repurposed molecules, varenicline now we have as a nasal spray. So these are things that hopefully these drugs will be more effective, get the appropriate medication to the target tissue, be able to hopefully have some improvement in tolerability. At the end of the day, though, we can have all the innovation in the world, and it's all about patient access. So if we have all these things and we can't get the drug to our patient because of their specific formulary or other challenges, that continues to be a big hurdle that we have to jump at some point. So I'm excited about innovation, but I'm always nervous about patient access because it's such a challenge in our clinics.
So Damon, let me ask you, so you have a patient now, they tell you, hey, you tell me about this inflammation, you tell me about this MGD, but I don't want to do drops. So how do you address that patient? Because we have to treat both. So what are you doing?
That's a great question, Walt. And I have patients all the time that say, I don't want to take drops. And we have multiple strategies. Of course, OTC products with lubrication and nutritional supplements are a core part of what we do. But if somebody doesn't want to use drops, one specific thing that we can do is in-office therapy. And in-office therapy, the two technologies fall under the photobiomodulation umbrella, intense pulse light and low-level light therapy. Those are things that I'm doing every week for my patients. Very good success there. And then if patients really don't want to be on drops long-term, we have ways, you talked about loteprednol, that we can actually treat flares, where maybe we are doing nutritional supplementation, we're doing in-office therapy, and then we're doing pulse steroids when they're having flare-ups, whatever may trigger that, whether they're on the computer a lot or it's allergy season, they're traveling, is doing drops, but for shorter periods of time, because there's just certainly some patients, I agree, that do not want to be on prescription medication chronically. But saying that, our innovations that we've had here the last few years, anti-inflammatory agents, lifitegrast, different formulations of cyclosporin, I think these drops are becoming more effective for our patients. I think generally more tolerable. And some of the things that we'll talk about here in the next section, looking ahead to 2023, I think there's a lot of innovation happening in the drop space. So I'm not ready to get rid of drops altogether, Walt, although some of my patients, I agree, would rather find a drop-free or less drop strategy if possible. So what needs exist in ocular surface disease for 2023 and beyond? And really this is the pivot that we want to, again, throw out to our attendees. Engage in the chat. What needs do you see in your clinics, in your patient base, wherever you're practicing, whoever you're seeing, what needs exist in ocular surface disease for 2023 and beyond? And hopefully with some of the innovation that we're going to be presenting, there's going to be some gaps that we're able to fill in the coming months to years. So Walt, I know this is something that's happening right now. As you see a patient like this that has nocturnal leg ophthalmos, what's the innovation that you've used in your clinic to help deal with this patient?
Man, this is gonna be mind-blowing. All right, so this is something that we're all gonna see, and this is something we have to look for, whether you're using the core Blackie light test, but looking at that lid seal and taking the transilluminator, having the patient close their eyes, transilluminate, see if there's any glow or any exposed areas where you'll see a red glow inferiorly. Because if patients have nocturnal light ophthalmos, we could put any newer drug, any current drug, any future drug on it. It's not the issue. The issue is going to be the exposure. And so, yes, we're looking at, what are some of the therapies, but we always have to take a step back, because if we overlook some of these things, patients are still going to be symptomatic. And so if you take a look, this is something I've been utilizing within the practice. So these are it's called Sleep Tight, Sleep Bright. And essentially what you do is you close your eyes. I've been using this for the last year or so, and just having that patient tape that eyelid shut. It's hypoallergenic. It's going to protect that lid seal. If that patient needs to get up during the nighttime and use the facilities, they can just take the tape off, put it on their nightstand, and then put it back on before they go to bed. But if it's an exposure issue, we have to treat the exposure. Traditionally, we've done always ointments in the past. There's some goggles as well, but I've had great success with these. Damon, have you used these at all? Are you using goggles, or what are you using for nocturnal light?
Yeah, all of the above. I mean, really a lot of different options, whether it's a gel and ointment. I do have good success with sleep goggles overnight, but I have probably 10 or 20 patients that we've prescribed this. I don't really have any immediate feedback yet. I've just been using it the last few months, but I'm glad that that's working well for you. And it's something that we sometimes overlook. I would say actually probably pretty commonly is these patients that wake up and their eyes are just miserable, or they're waking up overnight because their eyes are so uncomfortable. We really need something to protect their eyes. Obviously, we've always talked about avoid having a fan blowing at you when you're sleeping, but these patients that have this incomplete lid seal, I'm glad to see this product on the market as an innovation to help this problem that is really overlooked in our OSD population. When we look ahead to 2023, our first molecule, it's actually a novel molecule, a new mechanism of action, is Novo-3, or perfluorohexyloctane. I will refer to this
that fast
going forward. Perfluorohexyloctane is water-free, it's preservative-free. It's been available overseas since about 2014, but it's going through clinical trials right now. The trials are actually complete, and we're hoping that we're going to see this brought to market by Bausch & Lomb over the next sometime in 2023. They filed their NDA in June. The actual product is developed by Novaliq, and this product is a treatment that could potentially be on label for dry eye disease caused by meibomian gland dysfunction. So having a topical therapy, I know, Walt, you said you don't love drops for all your patients, but this drop is different, and we've not had this in the US. It is water-free, preservative-free, and it has really two main mechanisms of action. The first is it is a very potent stabilizer of the lipid layer. And what does that mean? We know that most patients that have dry eye disease have underlying meibomian gland dysfunction, and a lot of their problem is evaporative dry eye. And we've had treatments, and we continue to have success with treatments with warm compresses, thermal pulsation, other in-office therapies to be able to help stabilize the lipid layer. We know that certain artificial tears can help with that. But this is one that when you put a single drop on the surface of the eye, it can last up to 4 hours. So we now have a potent, long-lasting lipid stabilizer in the form of Novo-3. If approved, that could be available in the US as early as the first half of 2023. When you have this very small particle, it's 11 microliters in size compared to a water-based technology, which is typically 40 to 50 microliters. It has a ability to fast spreading over the ocular surface. So in addition to being that lipid layer stabilizer, we actually think it can actually penetrate the meibomian glands and actually improve secretions coming from those glands. So a very unique molecule, dual mechanism of action, preservative-free, does not really cause any sort of vision blurring, well tolerated. We'll take a look at this. So Walter, have you had some experience with this in a research setting in your clinic?
Yeah, so we were involved with some of these studies in the past, but this is definitely exciting because when we think about, who's that patient, when we talk about MGD, 86% or dry eye, 86% has an evaporative component. If we have an option potentially in the future that can address and stabilize the lipid layer, but also potentially getting in the meibomian glands and breaking up those obstructions, I mean, just imagine, complementary to a lot of things that we've discussed in the past, whether any of the MGD treatment, or maybe first line for many of our patients that have the signs or symptoms, and just the first start to get them going on their dry eye treatment journey. And so it's going to be pretty exciting if we get something like this.
So Novo-3, let's take a look at the phase 3 studies done in the US, Gobi and Mojave. These are multi-center randomized double-masked trials looking at Novo-3 with a saline as a control in patients with dry eye disease associated with meibomian gland dysfunction. Subjects had to be 18 years of age or older, have a self-reported history of dry eye disease, and then they were randomized 1-to-1 to either receiving Novo-3 or saline drops QID in both eyes for 8 weeks. The primary outcomes in this study were looking at corneal staining at day 57, or about 8 weeks after starting therapy, as well as visual analog scale dryness score, where you have a 0 to 100, with 0 is really no dryness, 100 is maximum dryness, and tracking that over time for the patient. So corneal staining, eye dryness is primary outcomes in these 2 large phase 3 trials. Secondary outcomes in Gobi and Mojave looked at dryness score at day 15, total corneal staining at day 15, visual analog scale for burning and stinging, and central corneal staining as well. Safety outcomes as you would expect in a dry eye trial. Looking at the demographics for both of these, you can see over 1,000 patients enrolled in these trials. A very similar, age between 55 and 60 for our mean age. About 70 to 75% of these patients were female, and a pretty good blend of both across race and ethnicity in Gobi and Mojave. So looking at the results from Gobi and Mojave, we had improvement in both signs and symptoms at day 57. Improvement in total corneal fluorescein staining, as well as eye dryness as measured by the visual analog scale. We can see that represented here in the top graphs, as well as the bottom graphs, looking at difference compared to the saline control. And this is exciting because this is difficult to do. Well, how challenging is it to have dry eye trials that meet both of these endpoints? Is that something that's very common or not?
Well, we've seen, for the symptoms, we've seen several different drugs get approved for the symptoms, but that total corneal fluorescein staining, that is huge. I mean, right now we have the inferior corneal staining that we've seen in some of the studies, but whenever we're looking at the corneal fluorescein staining, this covers everything. And so that is very impressive to me because it's been so difficult for many drugs, and drugs have failed in the past because they haven't been able to meet those endpoints. And so that's very impressive to me. And you can see just in the forest plots on bottom for both the signs and the symptoms, how it favors Novo-3 in both of those categories.
Looking at key secondary endpoints, improvements in as early as day 15, looking at NOVO3 compared to hypotonic saline, really at all time points, we saw improvements in favor of NOVO3 compared to saline. Looking at as early as day 15 for total corneal staining, as well as visual analog scale dryness, how dry are your eyes at this moment in time. So we have primary results at week 8. We have improvements as early as day 15 for this QAD drop NOVO3. Again, this is not FDA approved yet. The NDA has been submitted. We hope to hear some good news in early 2023. But I think that with this well-tolerated molecule, we've got a potential now, again, first time ever, to have a novel molecule that is approved for dry eye disease, signs and symptoms associated with meibomian gland dysfunction with a dual mechanism of action. We'll be expecting the 12-month extension trial, Kalahari, out here soon. Walt, any final thoughts on NOVO3?
I was just thinking about that total corneal fluorescein staining. I had a patient today that said, hey, can I get a pair of glasses? And he had about 3+ diffuse staining, and his vision was probably 20/40. And just thinking, if we can improve that staining, if we have potentially an on-label treatment, I mean, we can improve. Dry eye is a vision disease, but if we can improve that surface, this is only going to benefit our patients. And, that's how we're judged, is clear, comfortable vision and quality of vision for our patients. So that's why it's so important for us.
So one of the things that I do when I see a molecule or drug or something that's coming close to market is I start writing down patients on my chart or on my iPhone and say, this is a great candidate for NOVO3 if that's going to be approved. I've started doing that the last few months. These patients that have pretty significant meibomian gland dysfunction, where we've done everything we can to rehabilitate those glands. They're having to use lipid-based tears multiple times a day. If we can have something that can stabilize that lipid layer pharmaceutically, I think that's going to be a huge win for our patients.
Yeah, that's a great point. So let's take a look at blepharitis. And this is something that we're all very well familiar of. What do our patients complain of whenever they have it? Yes, we may hear of itching, but asking them, where does it itch? If it itches along the eyelashes, then we know it's blepharitis. And we're going to talk a lot about Demodex here shortly. But if it itches on the inner canthus, then that patient more or less has an ocular allergy. But here you can see the epidemiology. Estimated in office, 25 million patients may have it. And so that may be up to the prevalence that we see. But if you look at that picture on the top right, seeing those classic collarettes, that is pathognomonic of patients that do have Demodex blepharitis. But you can also see what the effects are, whether it's contact lens patients, whether it's surgery, whether it's just quality of life. But if we look at what are our current treatments, we don't have anything on label. I mean, right now, what are you doing, Damon? You have a patient with blepharitis. Well, how are you treating them?
Lots of different things. Again, we talked about photobiomodulation and in-office therapy. I've had really, I would say, good success, maybe not at eradicating, but controlling Demodex using light-based therapy with IPL, as well as low-level light therapy. I do that in combination with some sort of exfoliation, whether that's microblepharal exfoliation or something like Zest, where I'm using an ochre-based product to help remove that debris. And then I tend to favor ochre-based product for maintenance, but I do have lots of patients on tea tree oil scrubs as well. But no matter what, we're really not eradicating that mite population. We're controlling it to some extent and helping with some of the inflammatory things. So having the ability to perhaps something to get, again, we talk about root cause all the time, have something to actually get rid of the Demodex once and for all. I think this is exciting with what Tarsus has in development at this point.
Well, Damon, this is what I want to talk to you about. So let's go to the next slide. So if we look at collarettes, as I mentioned, pathognomonic sign of patients with Demodex blepharitis. And so it's just poop. It's mite poop that's on the eyelashes. We see the collarettes. You can see that's one of the underlined areas there, the 100%. So this was studied by Gal. And essentially, if you had collarettes, they pulled the lash, put it underneath the microscope, 100% of the time you had Demodex. Part of the study as well is if you're on lid scrubs, but they did not see Demodex, they pulled the lash 50% of the time, you still had Demodex, because you're not always going to see the collarettes, but the patient had blepharitis, and that's what they were looking at to see what is that association? But then for other patients that were not on lid scrubs, that did not have any Demodex or any collarettes, they pulled those lashes. Still 7% of patients still had Demodex. So you may not always see the collarettes, but if you see them, pathognomonic for patients with Demodex. And so one of the studies, I was involved with the study, you can go to the next slide, where we looked at 180 consecutive patients. Actually, hold off on this video. 180 consecutive patients. There were 8 sites. And what we found is 58% of our patients, just having them look down. If you don't have patients look down, you will miss this every time. But if you have them look down, see those collarettes, then we know they have Demodex, and we may potentially have a treatment to eradicate and kill those mites. But go on, let's play this video here.
Demodex mites are the most common ectoparasites found on humans. While they are highly prevalent in low numbers, an infestation of mites can lead to blepharitis and meibomian gland disease. There are 2 species of Demodex, folliculorum and brevis, that live on the skin of the face and eyelids. Demodex folliculorum inhabits the eyelash follicles where they scrape the epithelial cell lining with their claws and excrete digestive enzymes to feed on the oily sebum deep in the follicle, causing inflammation, hyperemia, and irritation. Both species of mites can carry bacteria on their surface or in their gut, causing inflammation of the surrounding tissue. Demodex brevis prefers the rich meibum in the meibomian glands on the posterior lid margin. As the mites thrive in this nutrient-rich environment, they begin to proliferate, causing disease by mechanical, chemical, and bacterial mechanisms. This leads to more tissue damage and blockage of the glands and follicles, leading to further inflammation. The overgrowth of the mites in the follicle leads to follicular distension, misdirected lashes, matarosis, and irritation. As mites proliferate, the partially digested epithelial cells, keratin, mite waste, and eggs combine to form collarettes, which can be seen with a slit lamp. These collarettes are a pathognomonic sign of Demodex infestation and are specific for Demodex blepharitis. Patients also experience other symptoms of blepharitis, including redness, lid itching, and eye irritation.
That's kind of disgusting, Walt. Thanks for that, by the way.
Yeah, you're welcome. So yeah, taking the veterinary approach to blepharitis. And so topical lotilaner, and that's what was submitted to the FDA recently here. And so here you can see targeted use is the treatment of DB or Demodex blepharitis. MOA is paralysis or death of the Demodex mites. Twice a day for 6 weeks. You can see the efficacy goals with collarette cure as well as mite eradication. And we go to the next slide. So take a look at this. This is very impressive. So this is just twice a day, and this was only for 28 days. There were no lid scrubs, no lid wipes, or anything used here, but you can see the improvement or the resolution of those collarettes and the blepharitis. And so, theories out there is the Demodex may be vectors for, let's say, staph blepharitis, seborrheic blepharitis, and so we may have a potential treatment, yes, indicated for Demodex, but for blepharitis itself. And looking at some of the early studies, looking at mite eradication, so you utilize this twice a day, you're going to see the eradication of the death of the mites, but over time, this will come back because these mites are ubiquitous. And so roughly about 6 months, we'll need to see those patients again, or may need to see those patients again and put them back on the treatment. So this is the Saturn-2, the top line results of a phase 3 randomized controlled double masked trial. But look at the primary endpoint, the complete collarette cure defined as 2 collarettes per lid at day 43. And you can see achieved by 56% of patients versus 13% of vehicles. And in these studies, patients had 10 or more collarettes to be included within the study. You can see it met its secondary endpoints, mite eradication, lid erythema, as well as composite cure rates. And so, Damon, that TP03, where do you see this? How often do you see this? I mean, what are your thoughts on this?
Well, we see it all the time. We were involved in a prevalence study, and 50% of all comers in our clinics have signs of collarettes. And if you have collarettes that are visible during your slit lamp exam, you have infestation of mites. So at least half of our patients that are coming in, whether they have dry eye or blepharitis or not, have collarettes. Who are we going to treat really is, I think, going to be the interesting part is We know that in the study, they had to have some lid margin erythema. So if we're looking at patients that have itching, that have red eyelids, that have maybe recurrent styes, have other dry eye symptoms, I think those are the patients that we're going to want to have those patients. We really want to have every patient look down, note the presence or absence of collar rest in your chart. I've been doing that for years because now, hopefully, I'm looking here, the NDA was submitted by Tarsus in September. Hopefully sometime in 2023, we're going to have a way to treat this with a twice-a-day drop. And I think there'll be some people that will just need a single course. I think there's others that are going to need to have chronic therapy. But this is something that this has a real impact on our patients. Patients can't wear makeup. They're always conscious of their eyes. Their eyes always look red, but they're always irritated. And now we have potentially a breakthrough for them to actually address the problem, which are these pesky Demodex mites that are living in their lashes. So, looking at safety, Walt, you want to comment on this?
Yeah, well, here you can see it was safe. 91% of patients reported the drop comfort was neutral to very comfortable, but no serious treatment-related adverse events were found on this.
So now we have a whole other thing to look at here, which is RASP. If you've not heard of RASP, you're going to hear a lot about RASP over the next year or two. The reactive aldehyde species. These are, pro-inflammatory mediators, and there's one in particular called malonaldehyde that is very common in patients with dry eye disease. They have an elevated inflammatory marker, a reactive aldehyde species or RASP, that is going to be part of their inflammatory cycle. And when we look at pro-inflammatory mediators and how we treat inflammation in the past, it's been more downstream, cytokines, T cell activation, the cyclooxygenase pathway, all of those things you remember in your studies. But if we look at what's actually happening, there's this RASP or reactive aldehyde species that is going to be elevated in anything that's inflammatory, whether that's allergy, uveitis, or dry eye. And we have potentially a new molecule, Reproxalap, that binds and it modulates RASP, and it treats inflammation at the top of that inflammatory cascade without the side effects that we would have with corticosteroids. We don't have issues with RASP inhibitors raising intraocular pressure or causing cataracts. It seems to be pretty well tolerated. Certainly things with cyclosporin and the Fitograst in some cases can be difficult for patients to tolerate. So we have a whole new way to address inflammation with RASP inhibitors if this is going to be potentially approved by the FDA. And Aldira, who's developing this product for both ocular allergy and hopefully for dry eye disease, is looking at submitting data and sometime in the fourth quarter of 2022 for potential approval for signs and symptoms of dry eye disease. We do have some press releases, the public information looking at primary endpoints achieved in phase 3 studies, the Tranquility 2 trial, looking at signs and symptoms of dry eye disease. And it was shown that the primary endpoints, look at those p-values, Walt, the Schirmer test 0.0001, and then the number of patients that had a greater than 10 millimeter response in Schirmer's, very statistically significant improvements with this novel RASP inhibitor called Reproxalap. Looking at other symptoms that we are going to be assessing in the dry eye trial, this is a press release from July of 2022. Reproxalap showed superior efficacy compared to vehicle in both primary endpoints of ocular redness and Schirmer test. But then look at all of those secondary endpoints. The secondary endpoints of dryness, discomfort, grittiness, stinging, burning, itching. It met all of those in this trial. That's very difficult, if not impossible to do. What's the takeaway for you, Walt, when you look at what Aldira is doing with the RASP modulator?
Never seen it. I mean, this hit every single endpoint, whether it's the call out, the primary endpoint, or any of those secondary endpoints, and not just statistically significant. I mean, look at those p-values; those are huge. And so this is potentially an exciting addition. Here you can see the acute secondary symptom endpoints. Purple is Reproxalap. The gray is going to be the vehicle. But you can see in all of these, just as Damon was mentioning, was very impressive data, highly statistically significant, and something potentially we'll have in the near future.
I think what's really interesting when you talk to some of the people involved in these trials is that this works immediately.
Yeah.
Within 5 or 10 minutes, you can get symptomatic relief the first time you dose the medication. We know we can do some things now with varenicline. We use a nasal spray. We get immediate improvement in Schirmer's. But think about immediate improvement in symptoms. We don't have anything like that, Walt. I think that's probably what I'm most excited about is that all of this data. But when you put the drop in, it can work right away. And I think that's very exciting if we have this potential for this, maybe in the fourth quarter, earliest time of 2023. I'm hopeful that not only could we have this potentially for dry eye, but we have so many patients in the Midwest that present with dry eye and allergy. It's all inflammation, and have something that we don't always have to run to a steroid to treat them, to be able to treat them in a different way by addressing their inflammation upstream. I think that's where the promise is with Reproxalap, is that we've never had a molecule like this to show this sort of result.
Hey, don't be selfish. We have those patients in mid-Atlantic area too, on the East Coast. But hey, on that last slide that you just had, while you were talking, I was looking at the minutes. And we just look at the minutes and how long it takes to address those symptoms. 30 minutes, 40 minutes on all those, just as you were saying. I mean, this is something, symptoms matter. And so we're going to have something that's going to help and work pretty quickly here for our patients potentially.
So we are not done with potential new drugs to the market in the US in 2023. Isol or cyclosporin 0.1%, again from Novaliq, I'm pulling up the data here, submitted as a NDA to the FDA in August. Walt, what can you tell us about Isol cyclosporin 0.1%?
Yeah, so this is from Novaliq, and you can see the excipient is perfluorobutyl pentane. And so this is going to allow for improved bioavailability and efficacy of the drug in the target tissue. And so we have the excipient itself, but a drug that we know, cyclosporin, traditionally increases the Schirmer scores, increases the tear reduction for our patients. No oils, no surfactants, preservative-free, small drop size, but a way that we can help address our patients potentially. You can go to the next slide. And looking at both the signs and symptoms. This was submitted to the FDA August 9th. Over 1,000 patients were in the clinical trials, whether it's the phase 2, B/3 Essence 1 study, or the phase 3 study of Essence 2, which is, and as well as its open label extension study. Next slide. But looking at the clinical signs, statistically significant reduction in total corneal fluorescein staining, which we talked about earlier. I mean, that is impressive. I mean, what does that mean to you? Improvement in total corneal fluorescein staining, Damon?
I think we've seen studies show improvement in staining, but whether or not that's clinically relevant is important. You know, looking at what is clinically meaningful, something that our patients are going to actually appreciate. Up to 70% of these patients had, 3 or more grade improvement in their total corneal staining at the first month. So that is, the majority of the patients have clinically meaningful improvement. We've had cyclosporin for a long time, but I've not seen data like this. So I'm excited about the prospect of having this in our arsenal as well to treat our patients with ocular surface disease.
That's right. The increased bioavailability. We're familiar with the increase in Schirmer scores. You can go to the next slide. And so the long-term study confirmed that the effect of cyclosol, which is that combination, was maintained and improved in most endpoints by 52 weeks. Safety and tolerability, you can see here as well. 8.1% of patients within the pool studied instillation site reaction, which we've seen in other cyclosporin formulations as well. But another potential option to increase the tear production for our patients. So we can go to the next slide.
So that is simply what we're looking at for 2023, if you can believe that. And we've got maybe just another couple of minutes left before we turn over to Q&A, a rapid fire. And I'll have you lead us through this. What are we looking at beyond 2023? What are we going to be talking about at Eyes on 2024, perhaps, in the ocular surface space?
You ready to go? Well, let's go. Well, hey, let's look at the dermatological approach. And we know about hyperkeratinization. It does happen. It's in the definition of meibomian gland dysfunction, but this is something that does occur within MGD. These disulfide bonds that cross-link, they harden within the meibomian gland and lead to the obstruction or the poor release of meibum onto the ocular surface. Next slide. And so if there's a way that we can utilize keratolytics and essentially just break up those disulfide bonds, this might be another opportunity for us to help address the MGD, to address both the signs and symptoms our patients may have. Next slide. And so if we have this keratolytics and they're utilized right now, some of you may have had a facial or chemical peel, selenium sulfide. So with dandruff, that's essentially what we're looking at here, using this dermatological approach for patients with MGD. We can go to the next slide. And so with selenium sulfide, this is Azura Pharmaceuticals, it can be used as a keratostatic to slow down the rate of keratinocyte proliferation or production. It can break up the keratin plug, so a keratolytic, but also lipogenesis to help increase the lipid layer. And so something still in the early studies, but maybe 2024 or beyond. Next slide. What else do we have? Plugs. Who loves plugs? David loves plugs. I love plugs. But looking at ocular therapeutics and utilizing a slow sustained release of cyclosporin in a hydrogel plug, preservative-free. We're all familiar with cyclosporin, lasts for up to 12 weeks. And so something that we could potentially utilize in the near future, 2024 or beyond. Next slide. And what about here? Is there a way that we can address specific receptors within the ocular surface, within the tissues, to help stimulate tear production, to address both the signs and symptoms of dry eye disease? And so here's another study right now looking at AR15512. You can see within the phase 2B studies, 369 dry eye patients over 84 days. The drop showed and maintained improvement in both the symptoms and signs, which was observed in as early as week 2. The company notes the efficacy was observed after the first dose, and that the drop appeared to be safe and well tolerated. But this is still something in the early stages. Potentially, we'll keep you informed about that in the near future. Next slide. What about clarity? And we've all heard about the clarity drops, and can we use this as a vehicle for both chronic dry eye? And they're looking at this one study, the SERP 100, looking at mycophenolate, sodium, as well as betamethasone, sodium phosphate. So utilizing a steroid combination in the clarity vehicle to address both dry eye symptoms and signs for chronic dry eye, but also we're hearing about dry eye flares and episodic dry eye, and so utilizing just betamethasone in itself, as well as the clarity vehicle. And then looking at thymosin beta 4, which is a sterile preservative-free drop. This promotes corneal as well as ocular surface healing by facilitating epithelial cell migration and increasing cell-to-cell matrix contacts, reduces apoptosis, as well as reducing inflammation. And so in the studies that were looked at last year, the RISE 3 that had over 700 patients, it didn't meet its primary income or outcome measures, but the company is still looking at this, trying to figure out how they can utilize this medication to help improve the quality of life, quality of vision, but also the signs and symptoms of our patients with dry eye disease. Next slide.
Yeah, well, that was pretty impressive. That was pretty quick. And the big question is, now what? So what? What are we going to do with all of this? We've seen molecules that have been reformulated. We see some new molecules to the ocular surface. What does all this mean? And this is where, hopefully in the chat, what are you most excited about in looking forward to 2023 in ocular surface disease? Walt and I are going to wrap this up. We're going to take some questions here to finish this session. I'm excited about having lots of different options. I'm always nervous because, so what? Now what? Can I actually get these medications to my patients? So I'm challenging the companies that are developing these different solutions. Help us get this to our patients as efficiently as possible, because it's such a challenge in our clinics with dealing with prior authorizations, and access is going to continue to be a theme here when we look at innovation in the dry eye space. Walt, any final thoughts as we wrap up the session?
Yeah, for me now, whenever we're looking at newer novel medications or treatments for our patients, because we got to think about, who is that patient? And we always get this question, I'm waiting for that perfect patient. Well, these are novel. These are things that we have to determine for ourselves. And as we go to Eyes on Dry Eye or Eyes on 2024, where we need to talk about it and share best practices, see how they work on mild patients, see how they work on moderate patients or severe patients, because that's the only way we're going to get the feedback. Because, with these drugs, we don't always want to wait for that patient that's tried every single drug and failed everything. We want to find a patient that has an early dryness, because the earlier we can intervene, the earlier we can minimize the signs and symptoms and the impact that can have on our patient's quality of life.
So keep your questions coming. There's been great engagement in the chat. We're going to go live for some questions here. Walt, it's been a pleasure as always. We've been doing this for a long time. 2023 is really poised to be a big year in ocular surface disease, and I cannot wait.
Me too. Thanks, Damon. Thanks all.
All right, look at all that excitement. So much chatter on dry eye. I mean, have you seen all this many applications for NDAs on dry eye go into place? This is great. Great overview on what to expect for dry eye pipeline. Looking forward to great things to come in the next 12 to 24 months. Thank you so much, Dr. Dierker, Dr. Whitley. But let's bring it back to the present, because with what we have now, there's still, there's a lot of episodic and chronic flare, and do steroids, where do they play into the management of dry eye? And we talked about IPL and all the different types of in-office treatments that were discussed. That was the chatter that was going on in the box as well. Walt, do you use steroids? I mean, where does that play a role in the management of dry eye disease for you?
Yeah, for me, I use steroids all the time. And so whether a patient that comes to me on artificial tears, oftentimes that's the first thing I'm going to go to, because it's going to address the signs and symptoms as quickly as possible, address the acute inflammation. I may need to turn over to some more chronic therapy, whether it's lifitegrast or cyclosporin, but I do always start with the steroid to quell that inflammation. So, but I do use it for episodic, because we know patients have dry eye flares 4 to 6 times throughout the year. And so we do have on-label treatments, loteprednol 0.25%, as well as fluorometholone is on label as well. But giving that to the patient, if they have a flare, use it 2 to 3 times a day for a couple of weeks. If it's not getting better, make sure they call us because it may not be dry or something else. Beautiful.
And then there's a huge focus on the eyelids, photobiomodulation. Dr. Dierker, who do you use when? Can you give us a little guidance there?
Yeah, that's actually interesting, Liz, because I was pretty sure that you were going to ask me what the next raffle code was going to be.
It might.
Anyways, so photobiomodulation, big part of my practice. We use low-level light therapy. We use IPL. A wide variety of patients can benefit from this. MGD, dry eye, rosacea. Low-level light therapy and IPL can work great for chalazion hordeola. And I would say that I look at some of my patients in a referral center setting, and I think about who isn't a candidate for these in-office therapies. And then we're combining that with nutritional supplements, lid hygiene at home, warm compresses. And then very often, these patients, especially if they're in that more inflammatory state, are going to need a prescription medication. And I'll use immunomodulatory therapy regularly. And then with steroids, I do empower my patients to have something like loteprednol on hand to be able to manage their own flares proactively. They don't always have to call my office, because I've empowered them to do that on their own.
Yeah, hey, Damon, that's a good point, because any of the treatments as well, steroids also do complement that. And so we utilize that. That's another key area.
Perfect. Well, thank you so much, Dr. Dierker, Dr. Whitley. And the raffle code is DME, like diabetic macular edema, all capital letters. Please note DME. And I think the audience, look at this. Look at how many thank yous are coming in. You guys are celebrities. Holy gee. I am honored to be in your presence tonight. Thank you for closing up our clinical lectures tonight with a wonderful lecture on the future of what the next 1 to 2 years looks like. Thank you so much.
And do not miss Eyes on Dry Eye 2023 in February.